Welcome to the Infective Endocarditis e-learning tutorial. This tutorial is designed to provide healthcare professionals with an overview of the pathogenesis of infective endocarditis and cover investigations, signs and symptoms, and relevant management. The importance of early diagnosis and management. Infective endocarditis is a life-threatening condition that requires immediate medical attention. Early diagnosis and management is important as it significantly improves patient outcomes. Delays in diagnosis can lead to severe complications such as heart failure, stroke, systemic embolism, sepsis, and potentially death. Prompt identification allows for timely initiation of appropriate antibiotic therapy and surgical intervention when necessary, reducing the risk of these adverse outcomes and improving the chances of a full recovery. Early diagnosis also helps prevent the spread of infection to other parts of the body, which can be particularly dangerous in immunocompromised patients. Therefore, understanding the clinical manifestations and risk factors associated with infective endocarditis is essential for all healthcare providers. Lesson 2. What is infective endocarditis? The learning objectives for this lesson are to be able to define infective endocarditis, to be able to explain the pathophysiology, and to be able to recognize the common causes and risk factors. We will begin by looking at the three main layers of the heart. The heart contains the epicardium, which is the outermost layer and serves as a protective layer and is part of the pericardium surrounding the heart, providing lubrication to reduce friction during contractions. Beneath the epicardium is the myocardium, the thick muscular middle layer, which is primarily responsible for the heart's powerful contractions and pumping action. And lastly, the innermost layer, which is the endocardium, a thin, smooth lining that covers the heart's interior chambers and valves, helping to prevent blood clot formation and maintaining a seamless flow of blood throughout the heart. A healthy heart is generally resistant to infection, as bacteria cannot easily attach to the surface of an intact, healthy endocardium. Infective endocarditis is the infection and inflammation of the endocardium lining of the heart surface, usually affecting the heart valves. For infective endocarditis to develop, there usually needs to be the presence of an abnormal heart valve, such as a prolapsed mitral valve, a bicuspid aortic valve, or the presence of a prosthetic heart valve. Additionally, there must be bacteremia, the presence of bacteria in the bloodstream. This bacteria will travel and adhere to the surface of an abnormal heart valve, forming a microbial vegetation consisting of clusters of bacteria, platelets, and fibrin. The formation of microbial vegetations in infective endocarditis is often preceded by damage to the heart valves. This damage can be caused by conditions such as rheumatic heart disease, a previous history of infective endocarditis, congenital heart defects, or the presence of a prosthetic valve. When the endocardium is damaged, it loses its ability to release protective molecules such as prostacyclin and nitric oxide, which normally prevent platelet adhesion. As a result, this leads to the formation of a platelet plug on a compromised valve, forming a non-bacterial thrombi. Once bacterial microorganisms enter the bloodstream, they can attach to and infiltrate these non-bacterial thrombi, forming a microbial vegetation. This triggers an immune-mediated inflammatory response, where recruited immune cells release proteases and reactive oxygen species, which contribute towards further damage of the valves and surrounding tissues. Circulating antibodies bind to bacterial antigens, forming antigen-antibody complexes, which can dissociate and enter the bloodstream. This leads to the deposition of these complexes in various organs, resulting in a systemic inflammatory response within the patient. Fragments of the microbial vegetation can also dissociate, forming septic emboli, which are infected blood clots that can travel through the bloodstream, leading to vascular occlusion and the dissemination of infection to various distant organs throughout the body. This can result in complications such as pulmonary emboli and strokes. Infective endocarditis can be classified into two main types. Acute infective endocarditis is characterized by an acute onset with severe symptoms caused by a highly infectious pathogen such as Staphylococcus aureus, which can affect both normal and abnormal heart valves, resulting in a poor prognosis, usually requiring surgical intervention. Staphylococcus aureus is a gram-positive bacteria that can enter the bloodstream through skin abscesses, intravenous drug use, or invasive procedures. Subacute infective endocarditis, on the other hand, presents with an insidious and slow onset, along with less severe symptoms. It is caused by less infectious pathogens, affecting normal heart valves, and has a relatively good prognosis as it responds well to antibiotics. One of the most common causative organisms is Streptococcus viridans, a gram-positive bacteria, which is part of the normal oral flora and usually enters the bloodstream through dental procedures and is common in individuals with poor oral hygiene. Other causes of subacute infective endocarditis include Haemophilus, Aggregatibacter, Cardiobacterium, Echinella, and Kingella, which are gram-negative bacteria. Summary of Lesson 2. For an infective endocarditis to occur, there must be an abnormal heart valve, which results in the formation of a non-bacterial thrombi. Secondly, there needs to be a bacterial source, which results in bacteremia, the presence of bacteria within the blood. This bacteria will travel to and infiltrate the thrombi on the abnormal heart valve, resulting in the formation of microbial vegetation. Abnormal heart valves can be due to prosthetic valves or native valve damage, which can be due to aortic valve disease, mitral valve prolapse, rheumatic heart disease, or congenital heart diseases. The bacterial source can be from IV drug users using infected needles, patients with poor dental hygiene, dental procedures, intravenous catheters, or cardiac devices. The presence of microbial vegetation will result in immune-mediated inflammatory responses, further damaging heart valves and surrounding tissues. The formation and deposition of antigen-antibody immune complexes, and the formation and dissemination of septic emboli. Lesson 3. Presentation of infective endocarditis. The learning objectives for this lesson are to be able to identify the signs and symptoms of infective endocarditis. The most common key sign of infective endocarditis is a new heart murmur, which results from damage to the heart valve. This can be heard through auscultation. The order of most common valves affected by infective endocarditis in descending order are as follows. The mitral valve is the most commonly affected. The aortic valve is the second most commonly affected. The tricuspid valve is the third most commonly affected. However, it is important to note that in IV drug users, the tricuspid valve is the most common one to be affected and is usually affected by Staphylococcus aureus. And lastly, the pulmonary valve, which is rarely affected. Fevers and chills. This occurs when the innate immune system releases pyrogenic cytokines, including interleukin 1, interleukin 6, and tumor necrosis factor alpha, which have a systemic effect that triggers a fever. Arthralgia and myalgia. Although the pathogenesis of musculoskeletal symptoms are not well understood, several mechanisms have been postulated, such as circulating immune complexes and deposition of septic emboli. It is important to note the classic presentation of infective endocarditis is a patient presenting with a new murmur accompanied with a fever. Other signs of infective endocarditis include petechia, which are pinpoint round red flat spots which appear in groups as a rash on the skin. They can be found on the skin surface of the extremities and mucous membranes, including the mouth. Splinter hemorrhages can also be present and would be visible as reddish-brown, straight line-like lesions located on the nails. Less common but highly specific signs of infective endocarditis include Osler nodes. These are painful, red nodules found on the pulp of the fingers and toes. They occur due to the deposition of immune complexes in the pulp of these areas. Janeway lesions. Unlike Osler nodes, these lesions are painless. They appear as hemorrhagic, blanching red spots located on the palms and soles. Roth spots. These appear in the retina and are visible during a fundoscopy, which are pale, oval lesions with surrounding hemorrhage that result from immune complex deposition in the retina. To close this section, the other systemic signs of infective endocarditis are night sweats, malaise, anorexia, and unintentional weight loss. Lesson 4. Investigations for infective endocarditis. The learning objectives for this lesson are to be able to describe the investigations needed for infective endocarditis. For diagnoses, 3 sets of blood cultures comprising both aerobic and anaerobic cultures should be collected. The blood cultures must be collected from different venipuncture sites and spaced at least 1 hour apart before starting antibiotic therapy. Each culture bottle should be inoculated with a minimum of 10 milliliters of blood for optimal detection. In unwell patients, empirical antibiotic therapy should be initiated immediately without waiting to collect all blood cultures. If the patient has a central venous catheter, it is advisable to collect blood from both the catheter and peripheral sites, as the infection could originate from the central venous catheter itself. Once culture results and sensitivities are available and the narrow-spectrum antibiotics have been commenced, blood cultures should be repeated 48 to 72 hours to assess the effectiveness of treatment. Culture-negative endocarditis can occur if antibiotics were administered before the blood cultures were taken. In such cases, or when standard blood culture methods fail to identify the organism, more specialized tests such as serological testing and blood PCR may be required. Echocardiography is a very useful diagnostic tool for confirming infective endocarditis, assessing complications, and determining prognosis. There are two primary methods: transesophageal echocardiography and transthoracic echocardiography, with the choice of use depending on patient-specific factors. According to the European Society of Cardiology, transthoracic echocardiography is generally recommended as the first-line screening test for suspected infective endocarditis in patients with a native heart valve. Transesophageal echocardiography, however, is preferred for patients with prosthetic heart valves or intracardiac devices, as it provides a clearer and more detailed view. A repeat echocardiogram is recommended within 5 to 7 days if the initial results are negative, but clinical suspicion remains high. Other tests and investigations include observations, urinalysis, and an ECG, as the progression of the infection can lead to conduction abnormalities of the heart. Whilst these abnormalities are uncommon, they are associated with worse prognosis and higher mortality. Blood tests include a full blood count. This may show normochromic, normocytic anemia, and neutrophil leukocytosis. CRP. This is a marker of acute inflammation, and monitoring CRP levels helps clinicians assess the response to treatment. Urea and electrolytes, to assess the kidney function and establish a baseline, as immune complex deposition in the glomeruli can lead to glomerulonephritis, resulting in altered renal function and subsequent hematuria and proteinuria, which may be evident on urinalysis. Liver function tests, to assess the liver function and establish a baseline. A chest X-ray can also be useful for identifying complications related to infective endocarditis, such as pulmonary abscesses, infiltrates, pleural effusions, or pulmonary edema. Early detection allows for prompt management and intervention. Lesson 5. Diagnosis of infective endocarditis. The learning objective is to be able to apply the modified Duke criteria for the diagnosis of infective endocarditis. In diagnosing infective endocarditis, there are two major criteria to consider. The first major criterion is a positive blood culture, which can be confirmed in one of three ways. Number 1, if typical microorganisms consistent with infective endocarditis are identified in 2 separate blood cultures. Number 2, if blood cultures remain persistently positive. Or number 3, if a single blood culture shows Coxiella, Brunetti, or an anti-phase 1 IgG antibody titer greater than 1 to 800. The second major criterion involves evidence of endocardial involvement. This can be established by an echocardiogram revealing vegetation, an abscess, or partial dehiscence of a prosthetic valve, or the presence of a new valvular regurgitation. In addition to the major criteria, there are 5 minor criteria for infective endocarditis. Number 1, a predisposing factor, such as intravenous drug use or an existing heart condition. Number 2, a fever above 38 degrees Celsius. Number 3, vascular phenomenon, like major arterial emboli, mycotic aneurysms, or Janeway lesions. Number 4, immunological phenomenon, including Osler nodes, Roth spots, or a positive rheumatoid factor. Number 5, microbiological evidence, such as a positive blood culture that doesn't meet a major criteria, or serological evidence of an infection caused by an infective endocarditis associated organism. A definitive diagnosis of infective endocarditis requires either 2 major criteria or 1 major criteria and 3 minor criteria, or all 5 minor criteria. Lesson 6. Management of infective endocarditis. The learning objective is to be able to explain the management of infective endocarditis. It is important to start patients on empirical broad-spectrum antibiotics as soon as blood cultures are drawn. In cases where the patient is critically ill, such as those showing signs of sepsis, stabilizing the patient using an A to E approach and immediate management using the sepsis 6 protocol, including administration of IV antibiotics, should not be delayed, even if the blood cultures have not yet been collected. The mainstay of management is parenteral antibiotics. When selecting the most appropriate empirical antibiotic regime, it is important to follow local guidelines and consult with specialists in infectious disease or microbiology, as recommended treatments can vary between regions. The key factors to consider when choosing the initial antibiotics include whether the patient has recently received antibiotics, whether the infection affects a native heart valve or a prosthetic heart valve, local patterns of antibiotic resistance, where the infection was contracted, whether in the community, during hospitalization, or in another healthcare setting. Once the blood culture results are available, usually within 48 hours, the antibiotic therapy should be adjusted based on the identified pathogens and their sensitivities to the chosen drugs. Further treatment adjustments are made depending on whether the infection involves a native or prosthetic valve. Surgical intervention usually includes the replacement or repair of valves and abscess drainage.